a little thing about the background, which you know all very much about, and I can just add again, first described by this gentleman there, Jacques Costello in 1977, and in 1998 there were 2 cases of rhabdomyosarcoma described in children with Costello syndrome, and then in 2005 we know the genetic lesion that causes Costello syndrome, which is a mutation in HRAS, and which activates or puts the RAS pathway out of equilibrium and is too active. These are gain of function mutations, and they drive the phenotype and obviously also in some children the tumor. There's, as we heard, an overlap with other syndromes associated with a RAS defect. And RAS, nobody said that before, actually stands for RASarcoma virus, because that's how RAS genes first were discovered. And it's very important for normal development, and if it's not functioning normally, it becomes from a gene to an oncogene, and that's what a proto-oncogene is. And that's what HRAS gene is in Costello. In 2006, there was a wider recognition that Costello individuals can have rhabdomyosarcoma, and also some cases of bladder lesions were described. And in RASopathies, which I find actually very intriguing, there are certain tumors associated with some others, like Noonan syndrome, brain tumors, also rhabdos, but also hematological malignancies, which we don't see in Costello's. And in Costello, it's mainly rhabdomyosarcoma. There are a couple of other cases as well. Of the 621 individuals in the literature with Costello syndrome, about a little bit less than 10% have developed a malignancy, and most of them rhabdomyosarcoma and a couple of bladder cancers as well. There are also a couple of neuroblastomas in the very young children, and a very small proportion, a surprisingly small proportion given the genetic defect, with other cancers, and they were as such, but most of them actually are rhabdomyosarcomas, and the others are very, very, very rare. This is the distribution of pathogenic variants in the HRAS genes in Costello syndrome, and as we heard earlier today, the GLY12 serine mutation or pathogenic variant is the most common one, and there is some evidence that in the other variants there might be even a higher rate in the G12 alanine, but the numbers are obviously very, very small to make this assumption as such. And the most common tumor is, as we said, the rhabdomyosarcoma of the embryonal type. There are 2 types of rhabdomyosarcoma. One is called alveolar, and one is called embryonal, and the alveolar is driven by another genetic lesion, which is a translocation. That's a pure oncogene between FOX and PAX genes, and that drives the transcription factor, and that is absent in the embryonal ones, and absence in most, if not all, cases of rhabdomyosarcoma in Costello syndrome. And you do that by looking at the patterns they look slightly less organized, and the alveolar ones form little patterns that resemble alveoli, lung basically, that's how they look, and they are not so positive for myogenin, but very positive for desmin, and they are obviously cells that were destined to become a muscle, and then decided for some reasons to become malignant. And that's what we see in Costello, and the maximal risk for these embryonal rhabdomyosarcomas is before the age of 6, and most of them are in the abdomen. And there's also the bladder lesions described, which happen after the age of 10. When rhabdomyosarcoma is diagnosed, it's treated normally, and I didn't find anything else. That's what we've done, and that's what other people have done I spoke to. You treat it like you would treat any other rhabdomyosarcoma, and follow the national and sometimes international guidelines with respect to the treatment of that. It's normally quite profound, heavy chemotherapy. The only always reliable complication, which is Costello specific, is the cardiotoxicity, and people look at that normally with the anthracyclines, which are certain chemotherapeutic agents. But overall, there's not much more toxicity described. And in the bladder lesions, the only thing that I found is that there is surgical removal. And there's very little experience with other treatments. The biology of these tumors associated with Costello doesn't seem to be a lot different to the one that occurs sporadically, but the numbers are obviously very small, and maybe one day we have enough material to really delineate that in a more comprehensive way, but at least they respond very reliable to chemotherapy. In some of these Costello-associated RAS variants, there seems to be a little bit of a worse outcome, which might be dependent on the genotype and the phenotype associated with it. So overall, the survival is by about 60 to 65%. Of course, these are very old data as well, which is not so different from the outcome of rhabdomyosarcoma in the general population or in the associated younger population, of course. If you look at the individual mutations or pathogenic variants in the individuals in the germline, then there appears to be a little bit worse outcome with the less common variants, but again, the numbers are very small. So because of that, there's some surveillance recommendations that should be implemented for everybody with Costello syndrome, which basically is a physical examination every 3 to 4 months in everybody under 10, and an abdominal ultrasound every 3 to 4 months for patients under 10. And obviously, if there was a tumor in the past, then one would carry on, but nobody knows how long. And for the bladder problems, an annual urine analysis is recommended. There are some people who also recommend a cystoscopy, but I'm not quite sure whether people follow this, because it's obviously a very invasive procedure of very, very little proven benefit when there's ultrasound and urinalysis available. There was a screening recommended for neuroblastoma associated catecholamine excretion, but that doesn't work because Costello syndrome in general has got abnormal catecholamine excretion, and therefore that is not done anymore. So overall, it's caused by HRAS, but why that gives only rise to rhabdomyosarcoma and none of the other cancers is what I find a very intriguing question. And why the risk is higher, gets drastically lower after 6 years of age is also something what I find very intriguing, because that's not the case in other cancer predisposition syndromes. And what is the optimal treatment for rhabdomyosarcoma in general is not really out there, and maybe the RAS activation can be targeted directly, but how that works in somebody with Costello is obviously out there to be tested. The screening strategies, do they really make a difference? And that means, of course, the cystoscopy. And I think also with other screening, it's very difficult always to justify, because the treatment would be very similar, even if you would pick it up later. But you have to apply some common sense there. So I also wonder whether we see a changing spectrum in cancers with people with post-Costello becoming older. So thanks very much. These are the 2 places I work, and if there's any questions, I would be happy to answer. No questions?
Question here.
Question. With the bladder cancer, what is the incidence of recurrence?
I didn't find any numbers for that.
Yeah.
I think it's very difficult to know because the follow-up is obviously quite short and the numbers are extremely small. I think there's very, very little data to give any data for that.
So if a patient had bladder cancer in the past, the best course of action would be the urinalysis every year.
I think if somebody actually has bladder cancer
has had bladder cancer in the past, then I think many places would advocate cystoscopies. Yeah, but I think that's something I would have to leave to the adult guys and to the availability of the procedure. But I think that's what's done also for sporadic bladder cancer.
Right, I was talking mainly of our daughter. She didn't have any of the rhabdomyosarcoma, but in her early teens she developed the bladder cancer.
Yeah.
And it was treated with laser.
Mm-hmm.
And then there was a recurrence.
Mm-hmm.
But they weren't actually sure if it was a malignant or a benign tumour initially. So she hasn't had any recurrence for the last couple of years. She hasn't had any recurrence for the last couple of years. And she's getting an ultrasound roughly every 6 months to a year. But obviously, we're interested in knowing what's the best course of action.
But I think the best course of action is something which we probably talk about in 10 years, when there's more data available, because I think we just don't know how easy we pick things up with ultrasound. But I think if you know what you're looking for, and ultrasound might actually be a very good way of doing this. You always worry whether every 6 months or every year a cystoscopy, if that's that's not what I would like for me or for any of my children. I think it's really difficult, and what I understand is that these lesions don't grow as rapid as rhabdomyosarcomas, so there is time. You wouldn't have to be so frequent and so fast with a response. Rhabdomyosarcomas can grow very, very rapidly, but bladder lesions are, from what I read, I've never seen that myself. I think Elena is the only patient with Costello I looked after. You talk about these things when you meet people who are interested in the genetic things of childhood cancer, but nobody has seen. I've seen 15 bladder cancers. Just by the numbers, if you think about it, 600 cases. Out of those 600 cases, 5%, which is 30 cases, you're one of them. So it's difficult to find lots of data that gives this is the way to do it. And I think we just have to kind of go forward and be a little bit pragmatic. What's available and what's actually feasible, and what the patient tolerates as well, because constant cystoscopies, I don't think with the other problems is maybe not the way forward.
Indeed. Thank you. Colin.
Hi. Lisa can move faster than me.
Thank you. I'm David Johnson. I'm going to be speaking to you in a minute about musculoskeletal problems, but my other half's a urologist, and I was having a chat to her about this very issue as to how to monitor. Also during my surgical training, I did 6 months of urology as well, some time ago. For adult bladder cancers, it's usually caused by smoking. It obviously affects the genetics, and it's a similar pathway that will have ended up in the position. I was chatting to my other half, and she did question the value of repeated cystoscopies, and that's a good reason to do it, because it is an invasive procedure. It's not very nice to have done. But it is a way of checking the system, and probably you're best speaking to the urologist who's looking after you as to what the best thing to do is. Which she said the one thing really to watch out for is symptoms. So there's two things to check for. One is if you get recurrent urinary tract infections, that will probably prompt a cystoscopy. And then the other thing is to get the urine dipped quite frequently, to look for blood in the urine that you can't see. And those two things, if done on a regular basis, obviously get symptoms, then fine. But get urine dips regularly, and then if it picks it up, then yes, that would prompt a cystoscopy. For adults, if somebody's had a bladder cancer, they will go on a programme afterwards to get check cystoscopies after that. So you'd have your treatment, it might be the laser, it might be cautery or whatever. And then normally what they would do is, that would often get done in the operating theatre under an anaesthetic, and and then they go to a check in the operating theatre under anaesthetic, and then switch it to a flexible cystoscopy. I think usually 3 monthly, once those are clear, 6 monthly, once those are clear, once a year, and then after that, again, on discussion with the urologist as to how frequent that should be. And that's probably the difficult thing to determine, is the risk of recurrence. So in adults, it recurs quite frequently. New ones appear because of the problem, and that relates to smoking. And so they do repeat it quite. Once you go clear a good period, then it's back to monitoring for symptoms. What the recurrence rate here is, no idea, like you've said, but it's worth bearing in mind, and probably at the very least be having dipping of the urine, and then discuss with the urologist as to whether repeat cystoscopies are worthwhile or not. But the impression I get is that they're, like I say, is not as invasive as the rhabdomyosarcomas. They are relatively treatable, even if it's a little bit further down the line. I don't think, certainly for adults, ultrasound's not particularly useful for looking at bladder cancer. So a negative ultrasound isn't maybe as useful as you think it might be. It's dipping the urine probably, and then a cystoscopy if there's symptoms.
That's very useful.
Is that helpful?
Yeah, because the urine analysis has never been suggested before.
Yeah, so you would normally get, if you've got a lesion there, it will normally produce blood. You won't be able to see it, but you dip it. If it's negative, that's quite reassuring. And if it picks it up, then a cystoscopy. But have a chat to whoever's looking after you. As long as you've got somebody who's sort of overseeing it, then that's probably the way forward.
Any more questions?